just heard about BRCA1 and BRCA2 and how important a family history of breast cancer is in determining their risk. And how we identify them and how we counsel them is important for BRCA. But we've now taken the step, and this will be presented by Dr. Marie Wood, as to how good and how well do doctors and oncology professionals do in obtaining these histories. Dr. Wood is professor of medicine, director of the Family Cancer Program, and deputy director of hematology oncology at the University of Vermont. Dr. Wood.
Thank you, Dr. Vogelzang, and it's really a pleasure to be able to present to you today our data regarding the quality of cancer family history and referral for genetic counseling and testing among oncology practices, as indicated by Dr. Vogelzang. Just a brief introduction. We heard a little bit about BRCA1 and BRCA2, but family history is really critically important in identifying individuals who are at above average risk for a primary cancer and should therefore get additional screening. It's also really important for cancer survivors who have a strong family history and then should get above average screening for maybe the cancer that they already have, for not only the cancer they already have, but for additional cancers. And family history is the best criteria we have right now to identify those people who are at risk for a hereditary cancer syndrome and candidates for referral and genetic testing. Genetic testing can then be done, and if positive, identifies those at great risk, as we just heard before, with genetic alterations, exposing them to additional risk and their family members. The purpose of this study was to measure family history taking and genetic counseling and testing practices among community oncologists using ASCO's Quality Oncology Performance Initiative, or QOPI. QOPI is an oncologist-led quality assessment and improvement program. As part of this program, practices evaluate the care of cancer patients with lung cancer, lymphoma, breast cancer, colon cancer around several domains, including chemotherapy administration, pain management, smoking cessation, and end-of-life care. We developed, and our group developed, pilot test questions for breast cancer and colon cancer patients. To develop these pilot test questions, we use expert consensus and participation from ASCO's prevention and quality committees. We looked at developing test questions around family history taking practices, around genetic counseling and testing referral, and also testing practices. Pilot testing of these measures occurred in the fall of 2011. 271 practices participated in QOPI's quality measures that year. Participation in these pilot test questions for breast and colon cancer patients was optional, but we obtained participation from 78 practices, 78% of practices participating, which resulted in gathering data from over 10,000 charts of breast and colorectal cancer patients. Surveying was done retrospectively, or a retrospective sample. QOPI identifies the 2-year window in which patients should be diagnosed. They should have had 2 visits within a 6-month period, and data was abstracted from charts from the most recent visit. And if we look at cancer family history taking practices that were documented, you can see here that a first-degree family history was documented almost 80% of the time for all breast and colorectal cancer patients. You can also see here that a first-degree family history was documented more commonly for breast than colon cancer patients. Looking at documentation of a second-degree family history, this was done less commonly. Less than 2/3 of the time was a second-degree family history documented for breast and colon cancer patients. And again, we see better documentation for breast cancer patients than colon cancer patients. When we look at the age of a cancer diagnosis in that family history, which is so important in really figuring out who's the best candidate for referral, we see that age of the cancer patients in the family was documented less than half of the time. This was, again, more commonly documented for breast cancer patients than colon cancer patients. And when we looked at the difference between breast and colon cancer patients, it was always statistically significantly different. When we examined referral practices for genetic counseling and genetic testing, if we look at all colon and breast cancer patients, we see that 22.1% of them were actually referred for genetic counseling and testing, much more commonly so for breast cancer patients than colon cancer patients. When we look at those people in the practice with breast and colon cancer patients who actually met referral guidelines for referral for genetic counseling and testing, less than half of them were actually referred or had genetic counseling and testing. Much more common, again, more than 50% of the breast cancer patients, but barely over a quarter of the colon cancer patients who actually met referral and current guidelines for referral were actually referred or tested. We then looked at testing that the practices did and were very encouraged to see that when a person actually went through genetic testing within that practice, consent was documented in the chart more than 3/4 of the time, and a result disclosure discussion so important in helping people understand these recommendations or these test results was documented more than 3/4 of the time. So what does this mean? Family history taking, we found a high rate of documentation of first-degree family history, but a low rate of documentation of age at cancer diagnosis within the family, a critical feature of figuring out who to refer. Family history taking is clearly better for breast cancer patients than colon cancer patients, and we're hoping to be able to do a little bit more looking at this data set to see why that might be. But I would suggest that we can and should do better. Thinking and regarding genetic counseling and testing practices, those who actually are tested are clearly getting good counseling, consent documentation, and such an important result discussion. But there are low rates of referral for those individuals who actually would benefit from genetic counseling and testing. And I would suggest to you that referral rates must be higher, as this really impacts cancer care. When we identify those patients with a genetic alteration, we then can manage those patients with additional screening, as we heard about, and they may also be candidates for different prevention strategies. Thank you.